have seen on the board, my lecture of today is clinical anatomy of the thorax. So when you talk about anything like clinical anatomy anywhere, either upper limb, lower limb, abdomen, thorax, pelvis, and anywhere in the human body, when you hear the clinical anatomy of that region, we are talking about the anatomy aspect of that portion in the clinic in order to make a diagnosis and treatment with regard to that portion. So when you hear this word, clinical anatomy of the thorax, we are talking about the clinical conditions affecting the thorax so that you can make a diagnosis and treatment with regard to the conditions affecting the thorax. Now, what are the conditions affecting the thorax? Conditions generally, whether in the thorax or anywhere in the human part of the body, can be either congenital or acquired. When we talk about the congenital anomalies, we're talking about something, conditions affecting the chest or the thorax while somebody, was developing in utero. That means inside his or her own mother's womb. So anything that you are born with, that is what we mean by congenital anomalies or hereditary, something that you have inherited from your parents. And then the acquired type is what you get after you are born. So for example, now after you are born, any disease condition that you can get after you are born, for example, somebody has an accident and has fractures in the chest, or somebody has a cancer of the chest, any part of the chest, whether from outside or from inside, all these are acquired conditions. Or anything that has happened as a result of environmental hazards like asthma because of pollens in the environment. So all these are what we mean by acquired conditions. So by the time all these conditions, whether congenital or acquired, they affect the chest. So these conditions generally, they are called, if you are able to make a diagnosis of these conditions and then you are able to make treatment with regard to that, that is what we mean by clinical anatomy. So when we talk about the thorax, we're talking about these conditions, either congenital or acquired. So, but before you now make a diagnosis in the clinic as a doctor or as a medical student or any other paramedical students, you have to do what we call examination of that portion of the body. We are now talking the thorax, so we are talking about the examination of the thorax. There are 4 different ways by which you can examine the thorax, what we call IPPA, IPPA. That means the first I is inspection. So you have to inspect physically, you see what is going on in the thorax. That means if you are a medical doctor or a medical student in the clinic, you have to ask the patient or the subject to remove his own clothes and then lie down on the table, examination table, so that you can see physically what is going on the chest. Physically, you now see with your naked eyes what is going on there. The next thing to do, after you inspect everything, then you can now do what we call percussion. Percussion, you are going to use your palm, you are going to use your hand, and then you put your palm on the chest of that person, and then you use this index finger, and then you start percussing, over different part of the chest, so that you now feel or hear the resonance of that, because, air gets into the chest, through our windpipe into the lungs. And so by the time you percuss, wherever you percuss on the chest, if you now reach the area where there is lung tissue there, the area is going to feel different from the area where there is no lung tissue. For example, where the liver is located in the chest, so when you percuss, the tone that you are going to feel is different from the area where there's lung tissue. We'll discuss this all along. I'm just giving you as a preamble. So the next part of the examination is to palpate. That means you have to put your hand and then you palpate every part of the chest and feel whether there are some, especially if you now put the hand inside the armpit, around the lateral side of the chest, you feel the lymph nodes, if they are enlarged as a result of disease or another. You also palpate the anterior aspect of the chest and also by the side to feel whether there are some masses, like the lumps, what we call lipoma and so on and so forth, which we'll discuss later on also. So you can also do what we call auscultation. Auscultation is to use your stethoscope. You know what is meant by stethoscope. doctors use that stethoscope on their ears, and then you now put the diaphragm of the stethoscope over the chest, and you hear different sounds, in the chest. For example, the air entrance inside the chest, you hear the sound, and also you listen to the heartbeat, when the heart is beating, So you also listen to the heart sound. You also feel the different, sounds of the air entrance of the chest. That is what we mean by auscultation. So these are the 4 different ways by which you can examine the chest. So now, apart from examining the patient by these 4 different ways, there are other investigations that you can use. These are also part of the examination. So these investigations that one can use or can do is something like what we call CT scan, computerized tomography investigation. So that CT scan, you can use it to also physically examine what is going on within the chest. And so you can also do x-rays. You know what is x-ray? I'm sure when you were just admitted into the university, most of you went to the x-ray room, and then you had an x-ray done. And so your chest, was delineated by the medical doctor that was, assessing you when you were just coming into the university. So you can do x-ray to examine physically what is going on inside the chest. And similarly, you can also do what we call ultrasonography. The ultrasound, can also be done. The ultrasound, you can use it to also hear the different echogenicity of the lung tissues, and also the other masses that are associated within the chest. You can also do what we call ECG, electrocardiography. This ECG is done on the heart, to delineate the condition of the heart. Somebody that has abnormalities of the heart, either congenital or acquired, like in the heart failures and what have you, you are going to hear different sounds with regard to the heart. Instead of you to listen to the normal heart sounds, you are going to hear or listen to different heart sounds in there. So you can also do what we call endoscopy. Endoscopy is just one instrument, what we call endoscope. That endoscope, you use it to put it inside the trachea, the larynx. You know what is larynx, I'm sure. So you put the endoscope inside the larynx, and then the endoscope will now go down through the larynx, go to the trachea, and then from the trachea it now goes down into the lung. Especially if somebody now swallowed something like small children, they can swallow a coin, even though we don't have much coins now amidst us, but they can always, or at times, swallow something like a beet, or beans. Small kids, they tend to play with, some stones or some beads. By so doing, putting them into the mouth, they can swallow, and unfortunately, it can go through the windpipe and goes down into the, lung. And so by the time you do endoscopy, you can easily see that, foreign body inside the, tracheobronchial tree. You get it? So these are the various investigations that one can do to inspect, That means there are 2 methods of investigation or examining or inspecting the patient. That means you can inspect the patient physically by using your naked eyes, or you can inspect the patient, the chest of the patient, by using some investigative, procedures like this, what I've already made mention, the CT scan, the X-rays, and so on and so forth. So now, if, for example, now the patient comes to you and you ask the patient to lie down on the couch or on the examining table, you are going to remove the shirt or the kaftan so that you can examine the chest, and you see or you examine if there is any associated deformity in the chest, or there are some extra ribs, what we call cervical rib. We have what we call cervical rib. This cervical rib, you can see it from this diagram, is an extra rib. You all know that we have 12 pairs of rib, 12 on one side and 12 on the other side. So this extra rib is what we call cervical rib. That means you have 13 pairs in that case. You may have 2, one on either side, or you may have only one on the right side or on the left side, or you have them both on either side on either side. So by so doing now, you have this cervical rib originating from the 7 cervical vertebrae. You know that we have 7 cervical vertebral bodies, right? So the last one, you know, that is from the transverse process of that 7 cervical vertebrae. That is where you have this cervical rib originating. And so this cervical rib is an abnormal extra rib that is found in less than 1% of the world population. So that means if you are 100, probably in this class, maybe likely one of you may have this cervical rib originating from this 7 cervical vertebrae. And so the textbooks, they may tell you that it is the prevalence of this cervical rib is about 0.5% of the world population. So now the importance or clinical significance of the cervical rib is, you know, you all know that at the upper surface of the first rib, you have some neurovascular bundles coming out from the root of the neck, and then they get out from the thorax, and then they come out into, you know, the upper limb. You know, we have our, you know, subclavian artery, you know, we also have subclavian vein. So the 2 important vessels here, subclavian vein and artery, they come out, the subclavian artery comes out of the chest into the upper limb, and then the subclavian vein enters into the thorax to drain into the heart. So you have these 2 great vessels, and then you have brachial plexus coming out from, you know, your C5, 6, 7, and T1. They come out of, you know, the root of the neck, and then they go into the upper limb. So this cervical rib, as it comes all the way from this transverse process of the 7th cervical vertebral body, so it may impinge on any of these important structures. That means the cervical rib may impinge on the closest, you know, trunk of the brachial plexus. That is the lower trunk of the brachial plexus. You know that brachial plexus has 3 trunks: upper, middle, and the lower. Because the lower is closer to this tip end of the cervical rib, that is why the lower trunk is liable to be compressed by the end of the cervical rib. Similarly, this cervical rib may also get attached to the first rib so that it forms a joint. Are you clear? By so doing, it may also impinge on either the subclavian artery or the subclavian vein. By so doing, if it impinges on the subclavian artery, you know the subclavian artery supplies where? The upper limb. So if it is compressed, that means the blood supply to the upper limb is going to be impaired. And so if the blood supply is not enough to the upper limb, what will happen? There will be some ischemic, you know, changes that may occur on the upper limb, some numbness and, you know, and certain sensation as a result of reduced blood supply because the axillary artery is being compressed. Similarly, if the subclavian vein is being compressed by this same cervical rib, you know, since the upper limb is being drained by this subclavian vein, so the blood drainage of the upper limb into the heart is also going to be affected, and so there is going to be an edema because the blood will be, will be static along the upper limb. So the upper limb affected is going to be edematous, is going to swell up as a result of this compression of the subclavian, you know, vein. Are you all clear? Good. So now we've seen part of the effects of this. At times, this cervical rib may not have any problem on the person that has it, probably because it has not grown big enough to compress any of the structures. So in that case, that patient is, you know, okay, because it doesn't have any effect on the close by structures. But if it is prolonged enough to even reach the end of the first rib, it may compress any of this or all of these structures that I've made mention. That is for the cervical rib. You can also have what we call lumbar rib. That means you can have the rib also originating from the the first lumbar vertebral body, because you know that the 12th rib, you know, originate from the 12th thoracic vertebral body. So the lumbar rib may also originate from the first lumbar vertebral body. So you may either have cervical rib or lumbar rib or both. coming at the same time. So, but the thing is that the lumbar rib doesn't have much effect because there are no important structures by which that lumbar rib may impinge. But the only thing is that it may confuse doctor when he or she wants to start counting the first lumbar, second lumbar, and what have you, because one may confuse himself that that first lumbar is the 12th thoracic vertebral bone. Are you clear? Unless and until you count from the beginning down to the, so you now see that there are 13 pairs of ribs. So that's the only way. Otherwise, it has no much issue. So after inspecting the root of the neck, you have not seen any cervical rib. So you now you inspect the chest movement, how the chest moves. That means if you want to know whether the respiratory rate of that person is normal, you will see that it expands and relaxes. If the person is just lying down or sitting up, you are going to see that unless the person removes his own dress, you will not be able to see the chest movement. So especially if the patient lies down on the couch and removed his own dress, you'll be able to see the chest expansion. And so by so doing, you can count what we call the respiratory rate. That respiratory rate is what we call RR. This respiratory rate is just about 15 to 18 per minute. So that means you will see that the chest expands and relaxes. That is one cycle. So that one, you count 1, 2, 3, up to 15 to 18 per minute in a normal adult. But in children, it's more than that. You get my point. So when you see that in an adult, this respiratory rate is more than this 15 to 20, expansion or relaxation per minute, then that means there's an increase in respiratory rate. That means you count that is about maybe 25 or even 30 cycles per minute. That means there's what we call tachypnea. That tachypnea, that means increase in respiratory rate. Or it may become lower than normal. That means it is below 15 cycles per minute. That is what we call bradypnea. That means decrease in the respiratory rate. That is what we call what? Bradypnea. So, but all in all, either tachypnea or bradypnea, the two together is what we call dyspnea. That means difficulty in breathing. We call it what? Dyspnea. So the tachypnea and bradypnea, they are all known as dyspnea. The P is silent. Dyspnea. You call it dyspnea, not dyspnea. So dyspnea is difficulty in breathing. So this one normally occurs in individuals that have problems with the respiratory airways or respiratory tract. For example, if there is a blockage of that respiratory tract, for example, somebody that has an asthmatic attack, you know what is asthma, we'll discuss that along the line. Or somebody that has swallowed a foreign body, like a coin or a piece of bone, you get it? Or somebody that has, a fracture of the, ribs, all this can cause difficulty in breathing, and that person may have increase in the respiratory rate, or probably later on decrease in the respiratory rate. So you may have either tachypnea or bradypnea, and generally you have what you call dyspnea. Again, when you examine that the respiratory rate is okay, then you now go ahead and examine whether there are some, associated chest anomalies. This, as I told you initially, what I was doing the introduction, I said that one may have congenital anomalies. In that case, you may have problems with the bone development, especially the sternum. So this is the manubrium of the sternum, and this is the body of the sternum. So in case that somebody has a problem with the development of the sternum, by the time the sternum goes in during the development, because if you now ask the patient to remove the dress, you see that the sternum, the body of the sternum is just like this, my embroidery is flat, like that. But for somebody that has an abnormality of the sternum, thereby it curves inward, that is what we call pectus excavatum. We call it what? Pectus excavatum. Pectus excavatum, it means that the body of the sternum, it depressed inward, it goes inward. That means if you look at the chest of the person by the side, you will see that the body of the sternum is carved inward. So it's depressed inward. That is what we call pectus excavatum. This is a congenital abnormality of the chest. Or the sternum may protrude forward so that it forms a bulge. So that even if the person now doesn't remove his own or her own dress, you will see the swelling in front of the chest. And that is what we call pectus carinatum. So this pectus carinatum is the opposite of pectus excavatum. So pectus carinatum is the protrusion forward of the body of the sternum. These are all congenital anomalies. So you will, by inspecting the body, the sternum, the chest itself, you are going to notice whether there are these abnormalities or not. So you may likely see pectus excavatum or pectus carinatum. This pectus excavatum is more or less common in boys. You get it, young boys, males generally. So, but in females it can also occur, but it's more found or commonly found in males, the boys themselves. So again, you may also have what you call kyphosis. Kyphosis, I'm sure you must have seen some of the people begging along the street. If you enter into the city of Kano, you will see that the vertebral column bends forward like this. So they have a convex back like this. So by the time you now look at the person, you see that the back, this is the head of the person, and then you see that the back is bent like that, convex back. That is what you call kyphosis. And so I'm sure you know that is as a result of the anomaly of the vertebral column around the chest region. That is the thoracic vertebral bones, they curved backward to form this what we call kyphosis. So this is what we call kyphosis. So the kyphosis is the bending or the convexity of the back of the chest. And then you may also have what we call scoliosis. Scoliosis, that means the vertebral column bends laterally. I'm sure you may likely see some people walking like this with the side bending. You get my point? That is what we call scoliosis. So the vertebral body now bends laterally. So at times, the person may have the combination of the two. The person has kyphosis and has scoliosis. Are you clear? Double anomalies. So you have what we call kyphoscoliosis. So you have what? Kyphoscoliosis. So a combination of the two together. So the guy has bent backward and laterally. So the person is just like this. Well, like this. I'm sure you must have seen one of these Vegas. The guy is very common. I think it's along Opera Pampo. When you go there now, the person is always there now. I have been seeing the boy. It's just big in there. So he has a combination of the two deformities I've made mention. Kyphosis and the scoliosis. That is one. Two, you may also have, certain conditions as a result of, diseases. For example, somebody has an accident and then the ribs get fractured. So if the ribs fractured, you may be able to see one side swollen, then the other side. Probably maybe the patient, when he comes to you, he was not able to talk to you, but you as a medical student or as a doctor, you should be able to recognize where the ribs are fractured. And so if there is a fracture of one or more ribs, certainly you should be able to notice that on the chest. And if you have more than two or more ribs fractured, you may have a condition what you call flail chest. That flail chest is a condition whereby you have, a problem with, movement of the chest. You get it? We'll discuss that one later on. So now we've seen, the condition of the chest by mere infections. So you can also inspect the breast. You get my point, because the breast is also on the chest and is considered part of the chest, even though some other textbooks, discuss the breast on the, portion of the upper lip. But then actually breast is on the chest. So there are several conditions that can also affect the breast. You all know that breast generally is rudimentary in males, but very prominent in females, especially when they grow, once they grow old, when they reach puberty. So by the time they reach puberty, the breast, grows bigger like that, and because of the hormonal changes, the progesterone and estrogen like that. Are you clear? So actually, there are certain things that you should also examine on the breast, especially now normal breast actually, it is lying between the second to the fourth intercostal, second to the sixth intercostal space, and then if it is a breast that is normal, when you now inspect it, you will see that it has a smooth contour like that and what have you. But a breast that has an inflammation, what you call mastitis. So the inflammation of the breast is what we call mastitis, and so that mastitis, mostly, takes place in women that are breastfeeding babies. So women that are breastfeeding babies, they tend to have this frequent mastitis. So you will see that the breast is swollen up and it's reddish in color, especially in a light complexion women that are light in complexion. You will see that the breast is red and swollen up. When you touch, it's going to be painful. When you touch, the woman will tell you that she's feeling pain, and then it is also warm when you touch it. These are the signs of, inflammatory conditions in the breast, not only in the breast, anywhere in the body. These are the 4 different signs of. There are at times when somebody may have, cancer developing on the breast. So cancer on the breast, prominently, you'll be able to see it with your naked eyes, especially cancer that has eaten up the entire breast. You will see that there is ulcer developing over the breast. Even at times the breast will be smelling and what have you, if it is a woman that you're examining. So by seeing that, probably the cancer might have gone into different part of the body, what we call metastasis. That means cancer cells moving from one place to another, moving from the original site to different part of the body. It may extend up to the brain, to the lungs, to the liver, and so on and so forth. That is what we call metastasis. And the cancer cells may pass through the veins or through the lymph. So either the veins or the limbs, they serve as a transport medium for these cancer cells. Again, we have certain anomalies associated with the breast, which you can also see with your naked eyes by mere inspecting the chest. That's what we call gynecomastia. Gynecomastia is just like presence of fully developed breast in men. Women now, we don't have breast. We have breast actually, but I told you it's rudimentary. It's not big enough. You will only be able to see the nipple and the areola around the nipple. That is the only thing you can see in male. But when somebody has gynecomastia, fully developed breast, you will see that the breast is just like that of a woman. That is what we call gynecomastia, presence of fully developed breast in male. And so that will results or becomes as a result of drugs. There are some drugs that people do take, and then they will develop the breast of that man to develop the gynecomastia. Not only drugs, there are certain hormones that if your own normal hormones, can misbehave, because normally the female breast, the estrogen and progesterone, we also have them in our own body. So at times in our own body, the progesterone and estrogen may get higher than normal. So if they get higher than normal, they may also cause this enlargement of the breast, and so the person may have gynecomastia. Are you clear? And then similarly, certain congenital conditions, the boy may also be born with this condition, the gynecomastia, especially in a condition what we call Klinefelter syndrome. If you can remember your, congenital anomalies while you are doing embryology, the person might have told you that, Klinefelter syndrome people, they tend to have gynecomastia. One of the presentation of this kind of people with this syndrome is the presence of fully developed breast when they grow up. Similarly, you may also notice polymastia. That means you see so many breasts in the chest, especially along the breast line. So you may see more than two breasts on the chest. That is what we call polymastia. You may see that on the female. You may also see that in the male. So, but in the male, since the breast is not fully developed, you will only see multiple nipples along the milk line, and that is what we call polytelia. That means the nipples, they tend to be multiple, more than one. Are you clear? So now these are the different anomalies that one can notice or can see with the naked eyes while you are inspecting the chest of a person. And then again, you may also see the sign of dislocation. You will see a protrusion along what we call sternal angle of Louis. Sternal angle of Louis is the junction between the manubrium and the body of the sternum, and that is the landmark for the the second rib that articulates with the manubrium of the sternum. So you have this joint, the sternoclavicular joint, or the sternoclavicular joint. You can also have clavicle also articulates with the manubrium. That is the sternoclavicular joint. You may also have a joint between the second rib with the manubrium of the sternum. So either of the two can dislocate. But the most important joint that can dislocate, and you see it prominently, is the sternoclavicular joint. And that joint, if it dislocates, you will see the medial end of the clavicle protruding forward like this. And so that, without being told, you will see the area being protruded like that. So all these are the things that you should be able to inspect while you are inspecting the chest of a person. So now you can see that there are so many things that one can see or diagnose by mere inspecting the chest of a person in the clinic. So let me just have a break here so that in case you have any questions, you ask.